So we're moving on to 3.5, which is the primary care improvement plan, and we've got a fairly comprehensive report in front of us and covering, I think, all aspects of the improvement plan. So, Jill, is Jill taking us through this, Pam?
No, unfortunately, Jill is away at the moment. Claire, I think, might still be on the call to answer some questions about the report.
If I can comment, no, unfortunately, Claire has had to go to another meeting. Jill's not available, so the report is given to us for noting. So I'm happy to take away any questions that anybody wants to raise and answer them out with the meeting if that's appropriate.
Thank you very much, Pam. So what we'll do, so again, on the basis that everyone has read the report, maybe just open it up to any questions, which Stephen will obviously, the recording will capture, and they might even be straightforward enough that Pam might be able to answer them, but on the basis that she may not be able to. But I think it is important that we give the opportunity to anyone who wants to raise any questions that Pam can take away, and Stephen will get us the answers from Jill. Probably why people, whilst people are pondering, I wonder if I could put Neil on this on the spot. His hand has just come up. I just wondered if Neil would like to, and I'm not asking him to speak on behalf of his GP colleagues. I wonder if Neil would like to offer his personal reflections and observations on the primary care improvement programme to date.
Sure, thank you. Yeah, I was just trying to click on the hand, but it didn't seem to want to go up or down. So I think actually this is quite a good little report, and it does summarise things very well. Actually, there's not a lot that I certainly find controversial in it. It's got both the good and that which needs to improve. And it's got a good background. There's a lot to PKIP, for sure. I'm not going to speak for all of my colleagues, but I think I can provide a little bit of a local view, because I think we've had some good points in Lochaber. So, for instance, the pharmacotherapy input has been excellent. The development's been really good, and the support's been really good. For most of the practices, it's had to be developed so that the service can support the practices further out from the centre, and that's almost like a microcosm of the Highland as a whole. So that's been interesting to see. I give you an example. I personally was really keen to have pharmacists embedded in the practice. Our sort of manager wanted to develop a hub, and I have to say that she was right. And the development of a hub, I think, has been better overall. I think it provides much better equity and has allowed a service to the more remote practices. So it's been interesting. So the original idea was for people embedded in practices, and yeah, we've slightly moved away from that, and I think that the service is better as a result. So that's just a small example of how things can develop. So you don't have to go with the original idea from the start. Other areas, it's taken quite a while for us to acquire primary care mental health service. And that's just, again, this is just reflecting what we hear all the time about recruitment. We've had a service, and then unfortunately that service has slipped a little, again, staffing, recruitment, and I think we're back on track. Vaccinations are really interesting. Tim might come in at some point here. It's certainly a side that Tim gets quite a lot of questions in AMC, GP sub, that side of things, and certainly a lot of my colleagues are quite mindful of possibly the costs involved in providing the service, whether it's as good value for money as if it had stayed in practices, whether it achieves its aims in terms of coverage. And I missed the last AMC, so I'm not sure if the numbers are out yet, but that would be interesting to look at. Again, just for members, a little bit of history. If you go back, quite a few of my colleagues in Highland, in GP Sub, LMC, which kind of overlaps in terms of membership, were keen to keep vaccinations, etc., in practice. Unfortunately, that was not basically just not allowed. It wasn't in the gift of where the money went. So some of us, myself including, were quite keen that okay, it would leave, because the whole idea was, as I've explained to you before, Jerry, is really to create more time for me to be able to spend with more complex people, developing older demographic, etc. But it is interesting to see that, well, I would like to see the numbers and see whether that actually, the movement of vaccinations out with practice provision is as good as if it had stayed. And yeah, we just got to see the numbers, I guess. I'm just having a quick look down. The MSK physios has been excellent. We've been able to have a physio in my own practice a day a week, and patients just really do benefit from that. Again, we've had to be mindful of and had to push back on possibly occasionally, I think, secondary care colleagues suggesting to people that they go back to the GP and get to see the physio there. That wasn't the idea. The idea is that somebody coming along can refer themselves to our physio, certainly for MSK. And they're supposed to have a limited role, but I know, again, they extend their roles a little bit. They look at people in a much more holistic way than you would imagine. Community link workers, again, the provision has been patchy, but when we've had one, it's just been great. And urgent care is quite an interesting area. I think most of us realised that there was no way there were sufficient funds to be able to provide, you know, an ANP driving around a car around Lochaber and seeing urgent cases. It just wasn't going to work. So I think there are some good ideas there in terms of using the monies available, because again, we've suggested that perhaps that tranche could move into other areas, and that's been batted back to us. No, it has to stay with urgent care. So therefore, people are coming up with ideas, and that's good. So overall, I think I'm quite impressed with where we're going at the moment. There's still quite a bit of work to do.
Thank you very much, Neil. Before I open it up to colleagues, maybe I could ask Tim just to come in on, well, anything in general, but particularly the vaccinations, if he could offer some observations on that.
Yeah, thank you, Jerry. Certainly, and thank you, Neil, for your thoughtful reflections on the issue. I think just as a background, I mean, the transfer was as part of the new GP contract, and I think that many people locally were not happy with that, but that's something that we have been tasked with implementing. I think in terms of outcomes, I don't think we've probably got the time to talk for hours on vaccination, but just in brief, in terms of the outcomes, I think there are two particular comments to make. I think we need to try to look at the outcomes holistically, as Neil was suggesting, about the time that is freed up from practices because of vaccinations not being done now, and what quality we can get out of that. and the overall quality within primary care and the overall service delivery that we're offering as a board and with practices to be able to say, is that an improvement through the new GP contract? When it comes to price, at the moment, I think that it's only a crude estimate, and it's not quite as stark, certainly, as some of the stuff in the press. I think that general practice would be cheaper at delivery than the board is. It depends on volumes, but as I said, the evaluation really needs to look holistically at what's delivered within practices, what's delivered in the board, and how it works as a whole. In terms of numbers, the numbers both for COVID and flu, although that was never fully delivered by general practice, so flu was, but COVID wasn't. But the COVID and flu numbers are okay, then they'll probably be in line with what we'd get. Certainly the stuff at the moment is reasonably good. It's not particularly high, but it is in line with the rest of Scotland for COVID and flu. Likewise, the figures for, we've got the first quarter for childhood vaccinations since the transition of VTP, and they are roughly on trend with what they were. So there isn't there's an overall decline slightly, but that's really a trend that goes along with the trend before the transition. So it's not something we want, and we need to get the figures up, but they're roughly on trend. So I don't think the actual numbers for implementation isn't the big thing, but what we've got a lot of dissatisfaction with the way that the service is delivered. People having to travel quite a long way and unhappy with that. There are issues around scheduling for the COVID and flu vaccinations. So I think that while we've got the numbers okay, we'd like to get them higher. We've got some. We do need to deliver. Do need to look at how we in the board can deliver that quality service, which is what people want and what people deserve. So I think that's where we need to go. But most of all, we need to look at things holistically.
Thank you very much, Tim. Neil, I found your reflections really useful there, and actually they tied up with mine, because I found this to be a very helpful overview of where we were or where we are in the primary care in improvement journey again. And we seem to have spoken a lot this afternoon about journeys and evolutions, and I think this is a good example of that, and it certainly ticked off lots of my questions and thought processes. What I'm particularly heartened to hear is that, not that I ever suspected there wasn't, but that there's actually been there's clearly been a discussion with GP colleagues when we've proposed a solution, and it's not been an imposed solution by anyone. There's been, and I think pharmacotherapy is a good example, as you quote there, that maybe the initial thoughts were in practice, but actually delivering it on a hub-wide basis is actually good. And that is really encouraging to hear that we've actually had that. Again, tying up with an earlier item in the agenda, that engagement and communication with GP colleagues, which is really good. I've got Councillor Burt and I've got Anne waiting to ask a question or two each.
Yes, okay, thank you. I think my question is probably another one for Tim, amongst others. I was just wondering, is there any sort of regular system of communication between health promotion and primary care generally? Funnily enough, it was discussed at a recent community council meeting I attended that to what extent were local GPs kept aware of what the health promotion department is doing such that they might support it? It obviously is relevant in terms of what Fiona Duncan was saying about linking families with children, for example. I mean, if there are policies directed towards children, it's obviously very helpful if the families know about them and support them and are compliant with that. I wondered, is there any system of regular communication?
Would you like me to answer that, Jerry?
Yes, please. Thank you, Tim.
I think it goes in a couple of ways. I think there is regular communication, newsletters come out and things like that from a health health improvement, health promotion point of view. Most of the connections that there are between health improvement, health promotion, and primary care are done on a more specific nature. The community link workers have already been mentioned, and they're one of the main ways. We don't have a comprehensive community link worker service. It is concentrated. There are one or two exceptions to this in special cases, but it's generally concentrated in areas of deprivation. So we have the community link workers there. They refer in, and they're well connected to the very well connected to the health improvement and health promotion service to be able to signpost and direct people there. There are also individual activities that have been going on in certain areas, whether on things like drugs and alcohol or suicide prevention, mental health improvement, where the links are made with practices, with primary care. So it's a little bit of a mixed picture. Like anything, no doubt we can certainly improve it, but I think there are good links, and Cathy Stearman, particularly over many years, has done an excellent job in a range of different areas getting those connections up.
Thank you, Tim. Are you okay with that, Councillor Burt? Want to come back on anything?
Well, it could be a long conversation, expanding in all sorts of directions, but that's a reasonable answer for a bit to be going on with for now.
Thank you very much. Anne?
Thanks, Jerry. So again, lots of useful information in the report, and it really interested to hear Neil's comments about the different work streams. What I was wondering, though, I noticed there was a reference to potential slippage. So I was wondering if anybody could give us an overview of where we are against this year's plan. What were what was the focus in terms of the work streams for this year? Are we on track with that? And what are the key risks in terms of potentially not being able to utilise some of the scarce resources that were set against the plan? And my other question really was prompted by listening to Neil's thoughts on what's worked and what's not, and having adjusted things as we've gone along. Is somebody somewhere gathering data to actually evaluate whether what the programme as a whole has achieved the objective of reducing or giving GPs the scope to play that different role? And is that a government responsibility, or is that our responsibility locally? Thanks.
Thank you, Anne. Pam, I see your hand up.
Yeah, thanks, Anne. In terms of your first question, then I can note that and provide a detailed response just around the finances and the spend. The second part, in terms of working with our GP colleagues, that expert generalist role, that's how we develop our primary care teams, and we evaluate that. I can also get Jill to provide something, and we can add those updates as an addendum to the minute, if that would be appropriate, Chair, so that everybody's got the same information.
That would be ideal. Thank you very much, Pam. Neil, I'm going to give you final word on this topic. Seems entirely appropriate.
Thanks. I'll come to Anne's second question. I think that's actually really difficult to answer, simply because we're in the midst of a workforce crisis as well, and I think every practice is really feeling the squeeze. That, it's obvious. So it's actually quite difficult to say, well, where would we have been had we not had PKIP? And just one final thought, if you'll allow me, which is positive, and it's not actually really mentioned in here, but I'd like to just say that certainly working I'm fortunate in working in a health centre with lots of people on site, and the degree of teamwork with our PKIP colleagues is excellent. So they really are in the team, yes, provided by board-funded roles, but they are very much, and we've really worked on that. So for instance, I personally have mentored somebody through their prescribing course. And this is part of keeping roles interesting and development and all the rest of it. Providing space in practice, you know, moving things around a bit so that we can provide, accommodation for people to be able to work, inviting them along, team meetings, etc. And so it can work. And I think certainly for that which it has been embedded so far has worked really, really well.
Thank you very much, Neil. I think even given that some of our questions are still to be answered, I think I'm still minded to actually say that we could proceed, or we can proceed to asking the committee to accept moderate assurance, because I think the report, and I think it needs to be passed on, I think the report was comprehensive enough that actually it gave us a lot of information, and that was added to by Neil's reflection. So I'm going to ask the committee if we're happy to accept moderate assurance on progress to date or on the primary care improvement programme. And again, outside of this meeting, I'll discuss with Pam when it would be appropriate to have the next update, and maybe at some point we will be able to answer that thorny question of evaluation of outcomes in the programme as a whole. But I totally accept what Neil has said. So are we happy to take that moderate assurance proposed by the report? Excellent, thank you very much. We'll move on to technology enhanced care overview. We again have another fairly comprehensive report been supplied to us with the papers, but I am aware that Tracy has a short presentation to run through as well, and I will hand over to Tracy.
Thank you, Jerry. There's a rather long presentation linked in the SBAR and I think included in your papers. You'll be glad to know I have no intention of going through all 20 plus slides with that. I thought what would be better to do today would be to give you the highlights from that and from the SBAR itself, and perhaps pose just a couple of questions which I'd draw your attention to the last 3 slides of that presentation, which are really, I think, the challenges for us as a partnership in terms of how we look at digital solutions for the future and being able to do things differently. So just a little bit of background. Technology-enabled care has been a hosted service in Highland for all of its lifetime, really. Lots of different projects sit under that banner over the years. It hasn't historically been really integrated very much with our eHealth or our D&I functions. In my view, if we are going to think about technology solutions, digital solutions to really support people using our services in the future, what we actually need to do is increase our integration between our eHealth provision and the innovations that come through our RD&I team. We can't continue to do these things separately. So that's my kind of fundamental premise and what I'd kind of ask the committee to think about as we go through this. What could we do differently that would actually use digital to transform our services? Because we know from evidence elsewhere that if we apply digital solutions thoughtfully and appropriately, we can help people to be independent in their own homes for longer. We could get people out of hospital quicker. We could stop so many people going into long-term residential care. We could reduce the size and complexity of our care at home packages. We wouldn't need so many people face-to-face to deliver those packages to people at home. And by supporting what they call patient activation and lifestyle and behavioural changes, we could actually support people to be healthier for longer, and reduce the burden of care in the longer term. So that kind of almost that public health intervention, really. So for those that don't know, technology-enabled care basically consists of 3 key work streams. There's telecare, which is the devices, generally the devices in people's homes. If you think of somebody that has the Lifeline pendant and the little box in the corner that somebody speaks to them if they have a fall and they call for help with their pendant, that's your basic telecare, your personal alarms. But actually within telecare these days, there's all sorts of things that we currently don't use in Highland. There are different kinds of sensors. There are what they call service robots. They're not the kind of robots that bring you a cup of tea, but they are devices that allow you to communicate with friends and family in a different way. They can help with prompts and reminders for activities of daily living, that kind of thing. And I've seen examples just this week of health organisations or health and social care organisations, I should say, down south in England that are saving millions with these kind of devices. They're saving hours and hours and hours of face-to-face care by employing these wider range of what we would call telecare devices. So that's one branch. The other branch most people will have heard of is the Near Me video consulting. And again, we were early adopters of Near Me. We pioneered this because of our remoteness and rurality, but we've actually fallen to the bottom of the league table for use of Near Me now. So I think there's a lot that we could be doing more and differently with this when we think about waiting lists and backlog of people waiting to be seen by specialists. And then the final one that I'll highlight as a work stream is called Connect Me. Now, this, you will have known this as remote health monitoring or telehealth in the past. So this is supporting people, particularly with long-term conditions, by giving them devices that connect to a central system that they can take their blood pressure or monitor their weight, you know, if they've got heart failure, and there's somebody somewhere looking at the readings that they're inputting or that are being collected automatically and is able to tweak their medication, call them in for an appointment, give them a call and ask them how they're doing. So this is helping people to stay healthier at home when they've got longer term conditions. And what we use now is a service that's provided on a Once for Scotland basis, free of charge. So for me, that means we should really be making the most of this. There are a number of different pathways on it, and we have a real opportunity, I think, in line with the national direction of travel here, to really scale up how we're able to use this for people. So those are the 3 main things that we do. So I started there to kind of say where we are with some of those. With telecare, we have just under 3,000 clients. We are increasing the numbers of clients by a small amount each year. So users have increased, referrals have increased, but we have fewer people receiving telecare compared to the national average when you look at our per head of population numbers. Telecare users per 1,000 population in Scotland is 23.5. In Highland, it's 14.6. So that's nearly 50% difference. And out of the league table of telecare service providers, 32 of them in Scotland, our rank on a national basis is 30th. We also charge more than anybody else for our telecare. So that's one thing to think about. I also, for the purposes of today, had a look at the number of people receiving care at home packages. 1,750 people when I looked at the data, and of these around 40% are receiving telecare. So I'm not sitting here claiming to know everything about every single one of those individuals. Those numbers do make me think, though, if we are really exploiting in the most constructive sense of the word, the ability we would have with telecare to support people better and differently in their own homes. We're also, at the same time as that, transitioning from analogue to digital telecare. Everybody has had in the past an analogue telephone line in their house. BT are transferring us all, whether we like it or not, to digital phone lines. So in line with that, we have to gradually, by 2025, change all our devices over to digital. So that's where we are with telecare. With Near Me, I've already said, I think we could be doing more in the way of remote consultations, video consultations. I think there are opportunities within the organisation that we could be looking at how we scale up, rather than just increasing the numbers of remote video consultations. Where could we target this to actually help us deliver services? Could we use it for training? Is it something that sits alongside teams? That there's different ways that we could use this system that we haven't yet explored. And then finally, in terms of Connect Me and the remote health monitoring, I'm old-fashioned, I still refer to it as remote health monitoring. We have blood pressure as our main pathway, and we're doing really well, got into a number of GP practices with that, but actually there's not many of our GP practices that have continued after training to deliver blood pressure monitoring by remote monitoring. And I can see why, you know, primary care GP practices have been extremely busy. Like everybody, they're having staffing shortages. It's new, it's difficult to kind of get used to using it and integrating it. However, we know that across Scotland, there are a lot of appointments for routine blood pressure monitoring. I do have the numbers in the paper and I actually can't find them now. I think it's something like, it's over 1 million appointments for routine blood pressure monitoring, 1.2 million appointments in 2018 solely for blood pressure checks, despite evidence that actually home monitoring gives you better results than in practice monitoring, and the evidence that remote health monitoring that engages the clinicians who are looking after the patients in reviewing the readings actually gets a much larger clinically significant reduction in blood pressure over time for individuals. So there's plenty of evidence out there that remote health monitoring for conditions like this is really good, but we don't have enough of it, I think, going on in Highland. And as we get more pathways nationally for the remote health monitoring services, I think we need to be looking organisationally at how we build this into how we do services. So what are the pathways we want to pick up? How do we build those into our existing services? How do we make that transformation from calling people in for appointments for routine measurements that they could now be doing at home themselves? How do we build a structure around that? So that's, I think, the main thoughts I've got about those three areas. And really my recommendation is that we think as a committee and we think as an organisation about that current position, where we are, what the potential is, what the challenges are for expanding and scaling up our provision so that we can realise the full range of benefits, how we integrate e-health, technology-enabled care, and our research, development and innovation work to really create that digital transformation. And that's really what the last 3 slides of the presentation are about. There's a lot out there we could be doing. We need to work differently to achieve that. So how do we do that? What do we need to do to try and make that transformation ball start rolling? So that's me. Shut up now and let you ask any questions.
Tracy, thank you very much indeed. I think it's an excellent paper for giving us an overview of where we are at the moment. And I've got a few folk who want to come in with questions and comments. I have got no doubt. But maybe if I just take Chairman's prerogative here, and maybe if I just ask Pam, because I'm quite sure Pam has had these thoughts with her team. Where does the opportunities and the challenges that Tracy has outlined here, Pam, fit into the current thinking in terms of that Horizon 1, Horizon 2, Horizon 3 work that's going on in the background? Because I'm quite sure the digital and technology opportunities are very prevalent in that, but been very mindful, I think, of something Joanne said earlier in the meeting, that digital and technology is not for everyone. And it's how do we make sure that we don't increase or create additional disadvantages for folk. But maybe because I'm quite sure, Pam, you'll give us something which will answer lots of folks' questions. Thank you.
Thanks. So Tracy, in this role that she's in terms of being a senior leader within the partnership, and now working directly with our digital infrastructure team, has brought to the senior leadership team many insights, just as she's outlined in that very well delivered sort of verbal presentation. Tracy, thanks for that. So Tracy attends our senior leadership team weekly. It's very recent, I would say, within the last 8 weeks, that we've become aware of the low uptake in Highland around near me, for example, and that was quite flabbergasting. So we have married that up with our urgent and unscheduled care work, particularly around delivering care at home and managing delayed discharges. And we recognise that the threshold from Raigmore, for example, in decision making to send people home would be much more positive if we actually had an uptake of telecare and more systems in place. And we do have to examine issues around, why we're not using Connect Me, why we're not investing in Near Me, why we charge the most. I know that through other leads that we followed up, then that we do charge the most for telecare, and that finance end up writing off most of that debt. So there's no benefits realisation there, because we've got busy finance teams trying to collect the debt of unpaid Near Me, when in fact people are not incentivised to take Near Me. Actually, if we offered it for free, it would be much better than occupied bed days around care at home, where people waiting for a care at home solution. So we need to work more with our public. We need to emphasise that much more in terms of our joint strategic plan. So where we had envisaged that we would have like an implementation plan and a financial plan and a workforce plan to deliver the joint strategic plan, we actually need a digital plan, to go alongside that to underpin all our interventions going forward. So we have the recognition, we've got the data that Tracy's been instrumental in collecting and working with the digital infrastructure team to articulate that and to help us as leaders in the senior leadership team and the partnership to understand what we need to do next and how we can enhance and improve our care delivery and our urgent and unscheduled care plans going forward, ultimately to help people live as close to or in their own homes, well supported going forward. There's just suites and suites and suites of digital technology out there that we actually need to embrace and take forward. So to give assurance, we are actually doing something about that, and it would be worthwhile to A, maybe have a workshop about it, or B, bring more specific assurance about what our interventions are around that digital technology piece back to the committee against our urgent and unscheduled care work streams, our plans and our ongoing plans to work across the system to engage with clinicians. One of the issues is around culture. We have created some technology aspects, and sometimes We've got variable uptake from clinicians about what they're willing to engage with, you know, in terms of delivering. If we look at the Discharge Without Delay app, for example, so there's a leadership piece around this and an infrastructure piece that we need to visit in terms of our whole workforce. But I'm happy to bring something back to the committee that articulates all of those elements together for assurance, especially going forward in delivering our joint strategy. Thank you.
Thank you, Pam. I think that's useful. I think you and I can have a think of how we bring something back to the committee, as you say, whether it's a workshop, a development session, or a paper to a future committee. I think that's important. I've got a few.
I just wanted to acknowledge as well that you know, Tracy is instrumental in being an expert in the field. You know, so bringing Tracy and keeping her in that space is
absolutely
very valued. Thank you.
Absolutely. So I've got a few folk, and I'm going to bring you in one at a time, and I am going to bring everybody in this because I think it is quite an important topic. I'll start with Kay.
Yeah, I just wanted to share my experience of telecare. My mum had telecare several years before she had care at home, but she never actually used it. I got a call once and left work at some speed and drove all the way to her house to find her in the garden and pottering around saying, "Oh, I've made a pan of soup if you want to stay." And ever since then, causing everybody so much fuss, the button went to the back of the drawer and was never seen again. She did pay for it for years, so she was always up to date with her bills. And later she did need care at home, but especially with older people, just because they've got a button doesn't mean to say they're going to be able to use it, and doesn't mean to say that these systems are appropriate for their care, you know. So I think that, you know, that needs to be taken into account, because you were marrying up the two figures, the people who had telecare and the people who had care at home. But it doesn't mean to say that those people don't also need a person going in, because this button could be in the drawer or it could be thrown out somewhere. And the other point I wanted to, it's really about the phone lines going digital, because obviously, from what I understand, when there's a power cut, they don't work. So that's good. You know, we keep a landline because of that. The thing is that if we get a power cut, we can't actually phone the company to say, when is the power coming back on, if we haven't got a landline. So I don't know what's going to happen in the Highlands when that eventuality happens. And
yes, my understanding is that BT are obligated to work with vulnerable groups to actually to ensure that they're out there. But what the exact nature and scope of that work here, I don't know. But it is a good point, and your point is absolutely valid. That digital is not for everyone, and we cannot go down that route, and we will not go down that route, and it's not a route we're even on. So, but absolutely, so I think we're aware of that. Muriel.
Thank you. And Pam has covered quite a few of my questions, but thank you to Tracy for that very enlightening presentation. I think there's just a couple of things resonating with me. Is that it's a shame that we have dropped down the national average. We were pioneers. We were on the front foot in this. So now that the senior leadership team seem to be aware of this, I think it's important that we engage and see what where we can assist and encourage, possibly, I don't know, I'm speculating, newer clinicians and newer people coming into the organisations that are less familiar with it. The technology, I think the cost you're talking about. I gave a talk recently to the visually impaired group in Highland, and that was one of the questions they asked me to ask. Why is there so much variance? You know, even in my own area, the cost varies between two different localities quite considerably, and one person said, look, I can't afford this. So I think that's an interesting reflection that we need to look at that as well. The digital thing, the time frame is quite tight. We know how things creep up on us. I mean, Jerry said at the beginning, this can't believe this is November. So we've got quite a tight time frame, and I would ask, with the permission of the chair, if we can get some feedback of everything that Tracy has highlighted to us at our next meeting. I think it's important. It's of that significance to us. But thank you, and thanks for Pam for you answering some of the questions.
We will try and capture something for the next meeting, Muriel. But I'm conscious that we've got something called Christmas and New Year in between us and the next meeting, so I don't want to impinge on anybody's festive period. But yeah, but absolutely, and I think the challenges and the opportunities are such in this that it warrants a bit of pace. But I will pick that up with Pam. Councillor Fraser.
Thank you very much. Thanks, Tracy. I mean, clearly it's there are huge opportunities here, and I'm not waste time on that today. I wanted to also highlight about this analog switch off. There are many areas in Highland that they still don't have any kind of digital connectivity. Some of our most vulnerable people will not have digital connectivity. And you know, when big companies talk about 98% coverage or whatever, we really need to be tying that down, particularly in Highland, to what does that mean for our people? Because the people that we can help the most are the people who are most remote. And on my understanding on the power cut issue is at the moment there is a requirement to provide some kind of backup, which will last up to an hour. Power cuts in Highland can be measured in days, sometimes not hours. So it is absolutely vital that NHS Highland, Highland Council, and everybody else here has got visibility of that, and if necessary, that we're lobbying at the highest levels to make sure that our most vulnerable people are not disadvantaged. Thank you.
I totally agree with you, Councillor Fraser. And again, I think I'll discuss with Pam exactly how we ensure that the board are sighted on this, and then actually use whatever influence we have, along with Highland Council colleagues, to make sure that the awareness of this is actually raised. Joanne.
Hey, thanks, Jerry. We'd welcome the offer for more detail in another session. I think Pam and Tracy have answered quite a lot of my questions. With relation to the digital switchover, I've switched over already to a digital line, but what it made me curious when there was the flooding and over in Aberdeenshire or south of Aberdeen, and where it kind of comes into emergency planning, because it's more than just telecare being switched off. It's probably access to health services and emergency services. So if people don't have landlines and mobiles are out of power and battery, there must be already been somebody thinking about it somewhere else. I was wondering about, Tracy, about the drop-off and near me, because I had noticed that, because I was obviously working alongside when near me was at the top of the league. I just wondered if there is capacity if it gets a push. So is there capacity within near me for us to push it to actually deliver? And the other query that I had was around the patient's response to digital being offered. There's not really much in the report around that, and around thinking of staff as to why it's not being used. I know some of it is out there in the community already. There's mentions of minimal costs associated, minimal investments. There's not really any costings, or do you think that the savings will cover the minimal costs or minimal investments that's required to push it forward? Thank you.
You want me to come back on some of
I think, Tracy, if you come back on the capacity issue, but I think the cost versus benefits bit we could probably pick up later down the line, because that could be a very, very convoluted argument in trying to associate financial benefits with something. But I think the capacity is a really key issue.
Yeah, I mean, I can just say a couple of words around where I'd put in the report about what we can do with minimal cost. There are some things that I think we could do that are fairly routine in other areas, that we could add to our arsenal, as it were, of telecare devices, for example. That would be minimal cost. I can't, absolutely, as Jerry says, I can't begin to quantify the benefits from doing that. I think that what I do propose is that there is perhaps a bigger piece of work that needs to go on around that to look at that whole cost benefit analysis. But certainly in terms of the capacity around Near Me, yes, absolutely, there are waiting rooms, which is the way they set it up on Near Me. There are waiting rooms for specialties set up that simply don't currently get used. There are group facilities on there, so a lot of group consultations, as it were, or group therapy sessions can be set up on there. So, for example, in mental health and in chronic pain and things like that, they do group meetings of people, and they're all set up and ready to go. So there is plenty of capacity. Some of it is about clinician preference. We survey through Near Me every patient who uses the service, and overwhelmingly all of the results we get from those surveys are very positive for patients using the service. Patients want to use the service when they have experience of it and they get on with it. They really like it. Obviously, it's not for everybody, whether you're a clinician or any other type of professional, or you're a user of the service. It's not going to be 100% for everybody. And it's about giving people the choice to be able to use that service. So people having the choice to whether they go to a face-to-face appointment or do that short appointment by remote video consultation. That's the main thing. I'm giving clinicians the choice as well for when it's clinically safe and appropriate to use the system.
Thank you, Tracy. Thank you very much for that. That's really helpful. Councillor Gunn.
Yes, thanks, Stuart, and thanks, Tracy. You've almost answered my questions. It's just obviously the Near Me, when it came in, it was going to be such a saviour for the people up in Caithness or anybody having to travel down for routine appointments. But I'm afraid there's still quite a number reporting back that they're going down and basically just having a blather with a consultant, and he says, "Oh, that's fine, I'll see you in another 6 weeks, 8 weeks time." So is there a reluctance, say, for consultants to use it, or is it patients? Is that where the main problem is? Because I personally, I think it's an absolutely fantastic idea. It's going to save so much traveling, in all kind of conditions and everything. And as I say, when it was brought in, it did reduce by thousands the number of people having to go down for routine things. But if there's a problem and we're ending up in the bottom of the list, I'm a bit worried about it, to be honest. Yeah, that's a point. Thanks.
Yeah. Absolutely, and I'd say I think that it's a lot of it is probably clinician preference, and I think that we don't always. I'm not an expert on how we book clinics and book people into clinics, but having been on the receiving end of that, personally and other members of my family, I know that Near Me appointments aren't routinely offered when appointments are booked to see hospital consultants. And so that's one thing that we could do, is so it's not forcing everybody into a video consultation. It's about having the people having the opportunity to take that option if they want to. And absolutely, I'm not a clinician anymore, but I absolutely understand that for some appointments, as a clinician, as a professional delivering services, you may well need to see the person in person, face to face. You may need to to see how they walk into the room. You may need to see their demeanour in a way that you can't get on a video consultation, or you may need to have somebody come in for tests and things like that. So there are some appointments that absolutely aren't appropriate for a remote consultation, but I think we're missing out on a lot that are, and particularly those ones that are routine follow-up outpatient appointments, no tests required, no scans, no x-rays, for somebody that's, you know, otherwise getting on pretty well, where they could be saved a whole lot of travelling, particularly in the kind of weather we've been having lately. I think those are the times when people are advised not to travel, and we've got people coming down to appointments a really long way. Actually, why don't we just bite the bullet and say, well, don't travel, but you can still have your appointment.
Thank you, Tracy. Final comment, thought, question from Cara.
Hi, Tracy. Mine was just more a reflection, just in terms of our policy around telecare, because sometimes my experience was that was a barrier in terms of how many responders an individual needed, and also thinking about the times in terms of travelling. And at occasions where I just wouldn't refer somebody for telecare, knowing that that was a barrier because of the policies that we have in place, and whether or not there's been any consideration to individualised risk assessments, thinking about individual cases where actually, you know, telecare could be a really good option, but it's maybe our policies that are causing that barrier. However, I do understand why they might need to be in place. So it's just more an observation on whether or not that's been considered.
Yeah, I'll just quickly answer that. I have been working with the telecare team to look at whether we can move to a more individual risk assessment basis around that. And I think there are some instances where we can do that, making sure that it's safe. You know, for example, one example was brought to me just in the last couple of weeks where we can't have responders living in the same house, but where a son lives with his parents, an adult son lives with his parents, but goes on holiday entirely separately, works, you know, separately. They lead separate lives. They just happen to be a resident at the same address, but we couldn't have him as a responder because he was at the same address, and it was felt he might go on holiday with his parents, and he absolutely doesn't. So, you know, I'm really all for let's bring some common sense into this and some proper risk assessment about the situation and looking at every factor. But you're absolutely right, that need for two responders really does trip us up when we're trying to support people with telecare. Other areas get around it in different ways. Their ideal solution would be if we had the ability to have a responder service, particularly overnight, and that's one of the ways that other areas get around this. So I do think it's one of the things we need to look at in the longer term for sure.
Thank you, Tracy. I'm sure that will be. I can see Pam nodding, so I'm sure that'll be one of the areas we think. I think we really do need to restrict this now. I think we've had I think it's about half an hour we've been on this, and I think it just shows the enthusiasm. I'm going to give Simon the very, very final word, so nobody else put their hand up.
Thanks, Chair. It's really just to say that I'm with Tracy on this. We do need to review whether or not the stringency of our policies, which is born out of previous problems that we had with the help call system, where people might have thought pressing the button was going to bring help and it wasn't necessarily going to. So I understand how it got to there, but we're in a different world at the moment. We're in a different level of provision. So there is a need for us to review our policy, and there is a need for us to become more flexible based on individual needs, individual circumstances, and this is the really important bit, the appetite that individuals have to take a risk to get something in place that's going to get them almost all the way to where they want to be, but maybe not that final bit. And then the final bit, again, as Tracy has rightly suggested to us, we do need to think a bit broader about what the infrastructure is around this. The key thing with any telecare system is that we have an infrastructure and a response that works to the level that we have agreed it's going to work, and I stress that. 100% of the time, because what we can't have is an assumption that it's going to provide some kind of support when it doesn't. So if I could just support where Tracy's going with that, but I would suggest to us, we do need to rethink our position around telecare. It probably requires to be a conversation that is taken with the joint officers around a number of issues. Part of it's a response, the operational response. Part of it's actually about the finance, and then bring a set of firmer recommendations back in due course, if that's okay.
Thank you very much, Simon. I think that's actually an ideal place just to wind this up, because you're absolutely right. It's not just the digital solution, it's how we operationalise that digital solution. What can we actually deliver as a response to all of that? And I think that's all of that. And I'm sure that's exactly what Pam has been thinking about through the senior leadership team in the Joint Officer Group. So I think that's been a really, really, really excellent conversation we've had there. I think we've been asked to note and discuss the report, and I think we can certainly say we have done that and accept moderate assurance. And there is no doubt we will be revisiting this in some format, probably in more than one format, over what I suspect will be a relatively short period of time, because there's many issues in there. So can I ask committee members if we're happy to note the report and accept the moderate assurance which is presented to us? Thank you very much indeed. And with apologies to all in the dreadful job I've made of keeping us to time, unfortunately Rhiannon has had to leave us, and so we've got no one to discuss the IPQR dashboard report. So I'm going to suggest that any questions anyone has on the IPQR are simply emailed into Stephen, and Stephen will collate them and get answers from Rhiannon, and we'll circulate those. Probably not with the minute, probably actually fairly in a bit advance of that, just so we're aware of that. I saw your hand go up and down, Pam. I don't know if that's what you were going to suggest.
Yeah. I mean, we've got ongoing pressures in adult social care, but you should note the work on care at home capacity, care home sustainability and flow, maybe around slide 6. It was a bit of a positive story, and reduction in weights and psychological therapy and growth in our SDS 1 and 2 around care at home. So there's good stuff in there as well as the challenges. So happy to answer any specific questions that people.
Those were the areas I had picked up as well, that we appeared to have stabilised some of the system, but there was definitely some good news stories in there. But I think we will capture that little commentary in the minute. But if I can suggest that any questions we'll just send to Stephen, and Rhiannon or Lorraine will answer them for us, and we'll move on that basis. Chief Officer's report, Pam.
Yes, very quickly, just in terms of our major redesign programmes, then we've been working with Kidness. There was a recent workshop on the 23rd of October, and we've been engaging more with general practice, which is a very important engagement. In Skye, we've kind of finalised the Sir Lewis Ritchie report and recommendations. He's exiting the programme. We've moved that through infrastructure work into kind of business as usual, in line with other areas that are doing redesigns, other districts and areas, so that's really positive. And the urgent care at Portree's ongoing. And Lochaber, we've done quite a lot of work around the community services redesign, and we've got a further 2 workshops planned. So that's really engaging and really learning from a lot of the whole system work that's been done up in the north that we're applying in Lochaber. We held the Joint Monitoring Committee, so just some highlights back from there that the Health and Social Care Partnership annual performance report was very well received, as was the Integrated Children's Services Plan. So both of them had been at the last Health and Social Care Committee. And Fiona did talk about this morning, earlier on in the meeting, about the whole family wellbeing approach. It's been a long day. So that's really positive. I did put in that point there about after the discussion at the JMC around the finance report, that the chief executives have arranged a financial workshop. So we'll be hearing more about the outputs of that. I wanted to say something about the challenges and risks that we reported to the Joint Monitoring Committee, because we talk a lot about them within the Health and Social Care Committee, and we'd be doing some work to establish a joint risk register that's articulated, because we have our risks within NHS Highland on our register, and of course the Highland Council, who retain the statutory responsibility, will have risks recorded in their system. So we wanted to produce a joint risk register so that was more explicit for the Joint Monitoring Committee. So work's underway to produce that. And then in terms of our ongoing operational risks that we have as a partnership, then I'll bring a full paper as an update to them. The committee have previously received updates. So I'll bring a paper to the next committee. The joint strategic plan, the engagement has concluded. Lots of positive feedback, lots of events have been held, lots of comments. So a thematic analysis is being drawn up, and we're going to take that back to the strategic planning group on the 6th of November, and we'll present that to this committee and the GMC and move towards publishing that. Again, just some feedback from the Joint Monitoring Committee. I think we just had to think about the language, you know, within the report. So we'll address that at the meeting on the 6th of November. But what I wanted to do was, you know, we spend a lot of time in our committee talking about, you know, the challenges that we have, the increasing demand and complexity. But, you know, despite that, and despite some very difficult working conditions, you know, working with agency staff, not working with full teams, dealing with additional demand coming in from the public to staff on the front line, then we've had some fabulous achievements despite all of that. So in terms of the Scottish Mental Health Nursing Forum Awards, then 3 of our teams have been recognised at a national awards ceremony, so that's really, really positive. And the Queen's Nursing Institute for Scotland Award, a very, very prestigious award, a very, very difficult award to get entry to. So we've got 2 nurses within the partnership who are going to receive that very prestigious award at a ceremony in Edinburgh in a couple of weeks' time. So I think some good news in there, despite the challenges that we have. You know, we have staff who still go that extra mile and who are highly committed to what they do. So I thought that was worth reflecting in my report this month. Thank you.
Thank you very much, Pam. I think it is always good that we recognise the efforts of our staff, and particularly when they're being recognised nationally with these prestigious awards. I think that is excellent. Any questions for Pam? I'll be happy to note Pam's report. Okay, we will move on. We're on the last leg, folks. We're on the last leg. Ruth, are you still with us? I see your name on the call for the Blueprint Improvement Plan update and the review of our terms of reference.
That's right. Yeah, I'm here with you, Jerry. So the Blueprint Improvement Plan. So maybe not everybody around this particular committee table is aware of the NHS Highlands Blueprint Improvement Plan. The board undertook an assessment earlier on in the year of all of its governance, and created an improvement plan which reads across to the NHS Scotland's good governance blueprint. The improvement plan has 17 specific actions, but only 3 of those actions effectively relate to the work of this committee and the Clinical Governance Committee. So it sits with the board, it's the board's improvement plan, but the board has asked for the individual governance committees to have informal oversight of progress. And I'll be putting a full report to the board at the end of January, which is a 6-month update. So I'm recommending moderate assurance on the progress that's been made so far, and you'll see in the appendix some of the commentary against the actions. So there's commentary there about the pilots for care opinion, for the Highland 100 panel, and activity that's already been started on the quality review. So this is just a snapshot at this point in time. And as I say, a formal full update will go to the board at the end of January. I'm probably not in the best place to give you chapter and verse of all of the various elements of the progress about the pilots. but this is a snapshot, as I say, and it's there for your information and for your assurance that elements associated with your committee are making progress.
Thank you very much, Ruth. Does anyone have any questions? As Ruth says, there'll be a full report going to the board in January, I think Ruth said. And we will keep revisiting it here. And we've already spoken about a few of the items which are there today, the Highland 100 panel and the care opinion. So although it's ostensibly about governance, I think it just shows that governance done well permeates across all the services. So are we happy to take the moderate assurance presented to us by Ruth today? Thank you very much. Review of terms of reference, Ruth.
Okay, well, yep. Again, I'll just get them on my screen. So your committee terms of reference, which are there for your review. I'll take your advice. In the meeting, there was just a couple of suggestions, which was to reconsider the attendees list. But if you want to leave those attendees on the terms of reference, that's up to you. So it's here for your review and your confirmation.
Anyone got? Oh, David.
Yeah, sorry, Jerry. It was actually reading your own terms of reference that made me reflect on the terms of reference of the JMC and our equivalent committee in Highland Council. And I don't think that, I'm not sure that any of us have properly reflected the role of the JMC within our terms of reference. And I was actually going to suggest that you may wish to consider deferring this item until the officers could maybe have a look at the role of the JMC and how each of our committees reports to JMC and our responsibility to JMC, as well as you've got the responsibilities to the NHS board. Highland Council, we've got a responsibility to our council. So sorry to drop that in at 4:25, but I think that, you know, if the paper isn't urgent, just having a wee deferral and get all three working better would be good. That's my suggestion. Thank you.
Ruth, does that approach cause us any timeline problems? It sounds eminently sensible to me.
That sounds very sensible. We can certainly look at that and bring that back to you next meeting if that's possible. I would usually be content for that. Yeah, I would usually try and sweep up all of these things by the end of the financial year. So you've got time between now and then to do that. Okay.
No, thank you very much for that, Councillor Fraser. I think that's very sensible that we've got sets of terms of reference that actually work in collaboration with each other. Okay, so we will bring that back to our next committee meeting in January. 4.3, we have the committee work plan, and it's really there for our last two meetings of the year, January and March, and that's really just there for noting. I would ask, I'm about to just sit down with Pam and Stephen and Ruth, and we'll start formulating the work plan for next year. So if anyone's got anything in there which they would really like to see is actually having a discussion about at the committee or at a development session, I would ask that you send those thoughts directly to me and we'll try and incorporate them into the work plan. But I would ask that we just note the work plan for the remaining meetings of the year. We happy to do so? Okay, any other competent business? I have got one, and I think we just need to come back to Wendy if she is still on the call. But I've got one just to say, and Ruth will keep me right on dates. We've got a development session on the 29th of this month, and I'm hoping to use a significant element of that, probably not all of it, but a significant element of that, to discuss a self-assessment, self-evaluation of the committee, which we at the Health Board we undertake on an annual basis. We had deferred them for the last couple of years due to the pandemic. The evaluation is based on a set of standard questions which we circulated to all members and attendees of the committee, and you're asked to give your thoughts, and it can be totally anonymous, or you can put your name on it. It doesn't really matter. Ruth and her team and myself will get involved, and we'll try and collate them all together, and we'll have a discussion in that. Ruth, can you just advise when the questionnaire would be getting circulated to everyone?
Yeah, I will. Just so I'm absolutely certain. I'm trying to look through my information right now on my desk. From memory, it's the 13th of November onwards for a fortnight.
Yeah.
So the middle couple of weeks in the month, and then you'll meet again at the end of the month to discuss the findings.
Excellent, and I would encourage everyone to participate in the questionnaire. Good, bad, or indifferent your answers be, it doesn't matter, and I will accept all observations about the chair's timekeeping failures in the spirit in which they're intended, and we will discuss that. And what I'd look to do then is actually to keep that action plan on our agenda to see, because the whole objective is to improve the operation and the efficiency, and actually and it relates very much to what Councillor Fraser had just said, how we actually help the system move forward in that regard. Okay, that's all I have. Is it Wendy? Is Wendy still with us? I'm not sure.
No, can I come in, Jenny? Wendy's not with us, but Cara McNaught is, and also she sent me a narrative just around the position of the carers breaks. So I was able to annotate that and put it into the chat. And I've also emailed Wendy because she was asking for it to be brought up under AOCB.
Excellent.
So the carer short break fund's going to reopen on Monday the 6th of November. There's dates for people to engage, and there's a carer conversation forthcoming in December. So it's in the chat in the first part of the meeting, because we did a new chat function for the break after the break. And I've actually emailed Wendy specifically with the information, so she's got it, because she had to attend at one point to see her son, so she's got what she needs.
Absolutely.
And
Pam,
thanks to Cara.
Thank you, Pam and Cara. Thank you very much indeed for that. That's incredibly helpful and useful. So at 16:28, we come to an end. The date and time of our next meeting is 17th of January 2024. But as I say, we've got a development session on the 29th at 1 o'clock, when I'm hoping, we will be discussing the self-evaluation exercise, plus other topics yet to be agreed between myself and Pam, and we better go on with it. We've got sustainability, I think, is what we're talking about there, and if possible, I would encourage everyone to attend. So thank you very much for your forbearance today and my very poor timekeeping. I'll have a chat with Pam as to whether the agenda is just getting a little bit too long, and we have to think about how we deal with that. So thank you very much today, and I am not at the 1st of November. I will see you all in the new year, and you can accept whatever formal greetings and felicitations there should be in that. Thank you very much. Bye-bye.
Thanks, Jenny. Thanks, everyone. Bye.
Thanks,
Bye-bye.
Jenny. Bye.
Bye.
Thanks, folks. Bye.
I'm weary, Pam.